project, we have decided to interview Dr. Kulkarni, who is a doctor here in Houston.
Hello, I'm Dr. Kulkarni. I am an MD in internal medicine. I work as a hospitalist. So I work in the hospital taking care of sick patients who are admitted with heart failure, strokes, infections, and some other medical diagnoses which are complication of diabetes, hypertension. I mostly practice in the hospital. I do not have a clinic because that's what I chose to do. My mother is my inspiration for being a doctor. When I grew up watching my mother, who's a physician, helping taking care of her patients, our family members, our friends, I always wanted to do what she did because I saw how rewarding it was, and I always wanted to take care of sick people, and that's why I decided to be a physician. I work at Baylor St. Luke's in the medical center. I work there as a hospitalist. My work hours vary, but most weeks I work around 50 to 60 hours a week. I work 12 hours a day, so my day starts at 7 in the morning. I don't physically go into the hospital at 7 in the morning. With remote access, I can start looking at my patients' vitals, their events overnight, and repeat their electrolytes and see what's going on with the patients. And I get to the hospital around 8:39. I see all my patients, talk to my consultants, talk to family members, come up with a good plan for the patients, and I get home by 4:35. I'm still available to my nurses and my patients till 7 because I'm on call till 7 every single day. And at night there is a covering physician who takes care of my patients for me and sign outs to me in the morning when I come back to work. I work every other weekend. Because I work in the hospital, there are all these sick patients who are in the hospital who have to be taken care of. So we choose to work 7 days and then I'm off the next 7 days. And our group is pretty flexible. So if I'm busy a specific weekend, I can always get coverage, but I do have to work on the weekends. But clinic doctors do not have to work on the weekends because they are open Monday to Friday. So every profession, depending on what specialty you're in, your work hours and your days you work are different. So being a young physician mom is very challenging, especially when you have little kids at home. You definitely need a little more help at home so you could focus at work. So having some good nanny helps. You also have to have a very understanding spouse because you have long hours to work, so that helps as well. You have to have a lot of multitasking abilities which you develop over years, and you just have to be very flexible with your day. You cannot be very you should try not to be very stressed about little things. You have to just go with the flow, be flexible, and just be relaxed so your day is smooth and you don't end up being a stressed person. I like the fact that I'm able to touch so many lives and take care of so many sick people in their most difficult times, and it's very, very rewarding. I do not like the fact that some days could be extremely long and I have to sacrifice a lot of family time, weekends, and also I do not like the fact that there is too much paperwork sometimes and insurance companies trying to dictate what we do with our patients. There are always some things that you love about your professions and some things that you would wish you could change. So I was raised in India. I did my med school in India. It was for 4.5 years, followed by 1 year of rural residency. We call it the internship in India, where you go to a rural area where there are not too many doctors. It's like a small village in India, and you take care of the poor and the underprivileged people. I did that for almost 1 year in India, came to US. I was an international medical graduate, or IMG, so I had to give qualifying exams, which are called USMLE. There are 3 steps to it. I gave all those 3 exams, and then there's a clinical exams called clinical skills test. I gave that, and then I could apply for our internal medicine residency. I applied all over US, and I was very fortunate to get into a program in California where I did 3 years of internal medicine residency, after which I could apply for the medical board of American Board of Internal Medicine, and I could start practicing as an internist. So in India, it was a very difficult academic program. We do not have access to all these computers and internet, where you have so much access to a vast knowledge and books and reading materials. We had to rely on smaller libraries. We had to write down notes when we were at lectures. So it was very different, but it was very hands-on. We had lots of underprivileged patients, and we saw a lot of complicated patients. Because it's a developing country and people are very poor, we could see a lot of complications because patients do not get medical treatment for years before they come to their doctors. So I was blessed to see a lot of sick patients, but I wish I had access to all the internets, so I could get a lot more reading material at the right time than relying on books, which was very exhaustive. They did, if not directly, they did lay a foundation for my medical school, and helped me get to that level. Without good grades in those college days, I would not have made it to the medical school. So I think it played a big role as I was growing into a physician. Um, Biology, I was always interested in human anatomy and biology, so that helped me the most, I think, because that intrigued, that increased my interest in medicine, and that's the subject that I loved, and that's how I decided that I would like to go in medicine eventually. To earn the title of MD, I had to go to a medical school, which was 4.5 years of medical training, which includes various different subjects of anatomy, physiology, and forensics, uh, and different subjects. And then after that, I did 1 year of rural internship, as I mentioned earlier. And I moved countries, so I came to US after that. So I had to give some qualifying examinations to get into an internal medicine residency. So I applied for that, and after I got approved for one of the internal medicine residency programs, I did 3 years of internal medicine residency, and that's how I became a MD. There are exams after completion of residency program by the American Board of Internal Medicine, which you have to clear, so you are a ABIM approved physician who can practice in different states of United States. Residency, the term as it says is residency because you literally spend hours and hours of your life there. It seems like it's your second home, or in fact you spend more time in the hospital than at home. So that's why it's called a residency. the duration is different based on what you choose to. For internal medicine, it was 3 years. It could be longer for some other residencies like surgeries um, or pediatrics. But for us, it was 3 years, and the first year is the most difficult year of your residency because you are trying to learn the whole functioning of the hospital, and your day starts at as early as 5 or 6 in the morning, and you have to see all the patients by yourself first, make notes, then see those patients again with your attending. Attendings are your teachers who are physicians who teach you how to take care of patients. And eventually, after you complete the first year, the second year you are a resident, you are called a first year resident. You watch over the little interns who are trying to learn how to take care of patients. And then the third year, you're the senior most resident. You are supposed to be taking care of patients with minimal instructions and guidance by then. In these 3 years, there are different exams that you have to give, and you are tested on different topics. So it's very rigorous training. For students who are looking into getting into internal medicine as a career, I would encourage them. It's very rewarding profession because you take care of patients with diabetes, high blood pressure, heart failure, so basic medical problems. But you take care of these patients, and you can send them to specialists when they need. It is very vigorous. The training is very intense, but once you have accomplished that, it is a very rewarding profession. Um, I always wanted to be a doctor since I was a little girl, but I did not know how complicated practicing medicine actually is. You could know all about diseases and treatments, but when you have to deal with a sick patient, it's much more than your medical knowledge. Uh, you have to have the heart to connect to them, get all the information from them, and understand where they're coming from, because you deal with a lot of difficult patients, depressed patients, aggressive patients, and you also have to deal with different specialists. You have to be in a competitive environment because it's also a profession where you have to succeed, and you also have to deal with these insurance companies. So all those things are never anticipated, and the long hours were something I was not aware of, but you get used to it because you see how rewarding it is, and you eventually build the endurance to work long hours and still be very rested and peaceful. I did do some research at Stanford when I came to US. I was with Dr. Van Den Berg. We did some research in virtual colonoscopy, and it's very good to be a part of the research. I wish I had more opportunities. If I did medical schooling in US, I would have done much more research, because that's how we come up with newer drugs or newer technologies, and research plays a huge role. It's always good to be a part of some kind of research while we are studying. During my research, I was an assistant to a Stanford physician who was trying to see how good virtual colonoscopy is. If you all know, colonoscopy is examination of the colon with a camera, and we go in to find cancers or some bleeding tumors or bleeding blood vessels or diverticuli. The project that I helped Dr. Van Den Berg was to see if virtual colonoscopy, which is actually a three-dimensional CAT scan of the colon, can be as efficient as a real colonoscopy. So it could be done on patients who are high risk for an invasive procedure and it would be less invasive and more time efficient because it needs minimal preparation for the patient, and the patient doesn't have to drink a big enema. So that was the test all about. So I I knew Stanford is a big institute and there are a lot of ongoing researches. So is Baylor in Houston. I was in California at that time, so I went into this big research institute and I looked up the physicians who are doing research, and I sent them emails to express interest in research, and some of them were looking for some research assistance. So they did accept my interest. They let me be a part of their research. So for students who are interested in them, they should try to see which field they are interested in. So if they could look into the latest researches in their interest of the field they are interested in, they should approach those physicians and see if they are interested in getting some research assistance, and apply for that. And you have to knock on too many doors. You shouldn't expect to be accepted in the first place you try, so you have to be very persistent in trying, because in medicine there is too much competition. A lot of people want to do what you're trying to do. So the first and the most important advice is you have to be very, very persistent, and if you know someone, try to ask them to ask their colleagues, and that way you can get in quicker than knocking on some unknown doors. I do. I speak Hindi, Marathi, and little Spanish, just minimal, just to get by. It's always good to know different languages because you get over the language barrier, as we call it. We have some patients who speak different languages like Tagalog, Persian languages, and it's a struggle to get through. But fortunately, we have some interpreter services now. We have little phones that help us, or we sometimes get lucky with family members who help us interpret. I have been in practice for 9 years. So, depending on whether I'm seeing the patient for the first time, which is called doing a history and physical of the patient, where I go in and get a detailed examination and detailed questions about why they came to the hospital, what kind of medical problems do they have, what kind of surgeries they've had, do they smoke, do they drink, do they use any illicit drugs, do they have any allergies. I ask them about their family histories, and the focus is on what brought them into the hospital. The patients I admit to the hospitals are very sick, so I have to get the details from them to understand what's going on with them. After that, I analyze their lab tests, their radiological data that I can see, and come up with a diagnosis. And then I have to write the treatment. I have to write orders for the nurses, orders for the pharmacist, so they could get the medicines they need. I order lab tests, more lab tests. I order some CAT scans, some MRIs, depending on what they need. So that's the initial assessment when I see those patients, which is called, as I said, the history and physical. A follow-up patient is easier. These are the patients that I've already analyzed. I know what's going on with them, so I go check on them the next day. It's easier. I just ask them follow-up questions. I ask them how they're doing the next day, if their symptoms are better or worse, which helps me decide whether I'm on the right track or I need to change the treatment or add some more medicines or change the current medication dosages. And some patients are going home, which is a lot of work as well, where I talk to the patients about any remaining antibiotics they need to finish up at home, any changes in their medications, the medications they need to stop, and their follow-up appointments with their own physicians. So depending on what kind of follow-up appointment I have with them, my duration with them is different every single day. So the number varies depending on whether I'm on call or I'm just doing my rounding, which is just seeing your follow-up patients. When you're on call, you may end up seeing 15 to 20 to 25 patients because you get all the new patients coming in from the ER, and you also have your patients that have already been hospitalized, your follow-up patients. And on just a regular rounding day, you see around 15 to 18 patients. You see them and some of them go home, some of them continue to stay in the hospital, and you might get some new admissions from the overnight physicians. So I practice adult medicine. So my patients are 18 years and older. So I've taken care of an 18-year-old and I've taken care of an 103-year-old patient. My patients are mostly from Houston, but we have a tertiary care hospital. So they come from cities, smaller suburbs next to Houston. So we always get patients that are very complicated that smaller cities or suburbs cannot handle. And they have a really difficult diagnosis because we are a multi-specialty center. We always get all these transfers from other smaller hospitals because we have super specialists to take care of them. Yes. So as an internal medicine physician, once you have completed the internal medicine residencies, if you choose to, you could do further specialization, which could be nephrologist who take care of kidney problems. You could go into cardiology, which is they take care of patients with heart disease. You could go into neurology, which takes care of strokes, seizures, and diseases of the brain. You can also go into dermatology, which is skincare. So there are different subspecialties, including pediatrics. There are different specialties that you could choose to go to if you want to specialize. So being the internal medicine doctor or the hospitalist, I end up being the primary admitting physician for most of the patients unless I'm a consultant. Most likely I am the primary attending on the patient, which means I am in charge. I have to decide which consultants come in and see the patients, when does the patient go home, and I try to triage them. I try to decide what happens to them the next day, and I am in control of most things that happen to the patient when they are in the hospital. The medical profession in today's environment has become very different than it used to be decades ago. It has become more, it has advanced a lot in terms of the treatments that we have to offer patients. It is also, technology has helped us save time on paperwork because we have electronic medical records which help us auto-populate a lot of information into the computers for these patients. We had to waste a lot of time handwriting all those details, but now it's getting easier, and with all the advances in genetics and pharmacology, it's getting very, very rewarding. Medicine is an ever-changing field, so there's latest developments, new recommendations, lot of recalls as we in our pharmacology, and the practice guidelines keep changing as well. So it's very, very important for physicians to be updated on a regular basis. We have to give the American Board of Internal Medicine exams every 10 years, so we can update ourselves on all the changes within those 10 years. There is also a lot of research. We can participate in different researches, read up a lot of updated materials, which is called Up to Date, Medscape. We keep getting all these articles from different institutes, and we also go for different conferences on a regular basis. We also have ethic conferences as well. We have to be updated every 2 years for these conferences, and it's called the continuing medical education, or the CME conferences. So we all do lots of those, and I'm a part of the Baylor medical center, so we have a lot of students, so we are updated with like a lot of academic information as well.
We would like to extend a very sincere thank you to Dr. Kulkarni here for allowing us to interview her for our project, and we hope you learned something from this video, and thanks so much for watching.